spécialiste dans le monde du pneumocoque et qui a fait des travaux récents extraordinairement intéressants et importants sur le rapport entre les infections à pneumocoque et la grippe. Et il est vraiment fait des lectures qui sont vraiment exceptionnelles, en particulier sur ce domaine qui est un domaine extrêmement important pour lequel on commence à peine à comprendre comment la grippe a tué depuis tant d'années. Je suis ravi qu'il ait accepté de venir spécialement pour vous faire une lecture. Donc soyez attentifs parce que c'est très, très important.
Merci Didier. So, unfortunately, having been born in the south of Africa, I don't speak French. So you'll have to understand my English. But it's a pleasure to be in Marseille. First time for me. I hear the bouillabaisse is good. So Didier has to prove this at lunchtime. But we are going to talk today about the pneumococcus and influenza. And the two are very important. We know that the #1 cause of death in children in the world is pneumonia. Okay? So not in France or US, but in Afghanistan or in Africa, young children die of pneumonia. And the most important cause of pneumonia deaths are bacteria. Okay? So the bacterial causes, and we know this because if you can treat pneumonia, if the children have an opportunity to receive a drug like penicillin, they are cured. So it's largely bacteria that lead to death. But there are many other causes of pneumonia, many viral causes. And so we will talk today about how the viruses can lead to bacterial pneumonia and death. So let's go here. Okay, so this is what started me thinking about this situation, and I will explain it to you. So what we have here is something called PCV9. So PCV9 stands for Pneumococcal Conjugate Vaccine, and it contains 9 serotypes. I have to explain some things to you. We have a vaccine that prevents pneumococcal pneumonia. Now the pneumococcus is a bacterium, and there are 93 different pneumococcal serotypes. A serotype is the capsule, it's made of sugar, and there are 93 different sugars. And the vaccine, which is an effective vaccine, protects only against the types which are in the vaccine. So this PCV9 is a vaccine that prevents 9 pneumococcal serotypes. And we know from double-blind randomized trials that the vaccine is effective, okay? But here we are not looking at the pneumococcal vaccine preventing pneumococcal pneumonia. This is the pneumococcal vaccine prevents hospitalization for pneumonia in patients with influenza. So we have here 87 patients who have influenza, and this is from a double-blind randomized trial. So there are 40,000 children altogether. 20,000 received the pneumococcal vaccine and 20,000 did not. And you would not expect a pneumococcal vaccine to prevent influenza. There's no reason for a pneumococcal vaccine to prevent influenza. In fact, we don't believe that the pneumococcal vaccine does prevent influenza. So why are there less cases in the group who received the pneumococcal vaccine than the control group? The reduction is nearly 50%. It's not that the pneumococcal vaccine prevents influenza. It's that when children are admitted to hospital with influenza, they have influenza plus pneumococcal disease. And by preventing the pneumococcal disease, you prevent the severity of the influenza so that children are not hospitalized. So when you have influenza comes through a community, you can have 20–30% of the children can be infected, and that has nothing to do with the pneumococcus. But a small number come to the hospital, and we believe that about at least half of those who come to the hospital come because they have a pneumococcus. Now, this percentage, 45%, is a minimum percent of the pneumococcal contribution to influenza pneumonia, because the vaccine only prevents 9 out of 93 pneumococcal types. So then any other type of pneumococcus complicating influenza will not be prevented. So this is a minimal estimate. Okay, sorry. So let's look a little bit at this interaction of pneumococcus and influenza in mice. So these are not my data, but it's from a collaborator of ours, John McCullers. And this is in mice percentage survival. You can give mice influenza. This is a low dose of influenza, 1/20th of a lethal dose, minimum lethal dose of influenza, so that they do not die. And then you can give them a very small dose of pneumococcus. This is a very virulent pneumococcus. The mouse model is not an ideal model. I will show you some data from monkeys in a minute, because mice are not susceptible usually to pneumococci which infect humans. So this pneumococcus here is a type 3 pneumococcus that will kill a mouse, and they used 2,000ths of the minimum lethal dose, and it still kills 1 mouse. So percent survival pneumococcus alone is 90%, and survival of influenza alone is 100%. Now you do the same experiment. You give the same dose of influenza, but then you give the pneumococcus 7 days later. So an influenza that should not kill a mouse, and then you follow 7 days later with the pneumococcus that should not kill a mouse, and now you have 100% death of the mice. So you are all scientists, and you say, okay, what happens if you do the experiment the other way? You give pneumococcus first, and then influenza. What happens to the mouse? And I won't go through all this, but it's this line here. Pneumococcus followed by influenza. So if a mouse sees a pneumococcus and then afterwards sees influenza, it's no problem. But if it sees influenza and then in a window, and we know the window is small, it's 7 days in a mouse. We think in monkeys it's 4 days, and in humans it may even be simultaneous. There's a problem. So the human body and mammals, our immune system can deal with a virus. We can deal with a bacterium. But when the two come together, and I don't think it's always chance they come together, because I will show you they transmit together, then you can have a problem. Okay. So this is the same type of experiment, but now in monkeys. And it's old. It's been in the literature for 35, 38 years. So this is what you call they call the viral control. So they gave influenza virus to a monkey, and they count the pneumococcus, Streptococcus pneumoniae, the bacterium in the blood and the lungs. So if you give influenza to a monkey, you will not expect to have a pneumococcus in the blood, because the monkey has never seen a pneumococcus. And then they have the bacterial control, and so they just give this Streptococcus pneumoniae to the monkey, and they find in the blood 5.5 times 10, so 55 pneumococci per milliliter of blood, and 90 per milliliter in the lungs. Then they do the same experiment I showed you in the mice, but now it's 4 days later. So you give influenza first, and 4 days after you give pneumococcus. Instead of having 55 pneumococci in the blood, they have 3 times 10 to the 4th, 30,000 per mil of blood, and more than 100,000 in the lungs. So when the bacterium follows again the influenza, there's a massive increase in the density of the bacteria in the blood and in the lungs. Okay, I'll go a little bit about the mechanism. We don't know for sure the mechanism, but the predominant idea, and this is back in mice, is when you follow the mice, remember the pneumococcus could not be killed 7 days after influenza infection. So this is colony forming units, number of pneumococci, 7 days. So if you expose the mouse at day 3, day 5, no pneumococcal growth. You expose day 7, you get it. And they made the observation that the timing of interferon-gamma production, so this is a cytokine which is produced in response to the influenza, is exactly the same as the time when the pneumococcus cannot be killed. And because they are mice, they can do nice things. To take an interferon-gamma knockout mouse, so you would find here that knockout mouse, so interferon-gamma receptor knockout, no mortality, but the wild type mouse is this one, the mortality. And you can have interferon-gamma knockout, so this is the mouse does not produce, this is the one where the receptor knocked out, the same thing. So the story is that the response to the influenza, the interferon-gamma response in some way facilitates an inability to kill the pneumococcus. And there's a whole theory about this, we can talk more. It's related, they think, to the marker receptor, which is a scavenger receptor. The alveolar macrophages, which can kill pneumococcus, are influenced by this receptor. Okay, so I've told you that there is a severity consequence of having a pneumococcus after influenza. There's also some very interesting data on transmission, and I'll go a little bit fast through this because I want to return. So this talk is going to be, we've talked about severity in animals. Now we will talk a little bit about transmission, again mainly in animals. And then I want to talk to you about 3 things. The 1918 influenza. You will all know that that was the worst influenza pandemic with estimate perhaps 50 million human deaths. And the question is, were all those deaths just due to influenza, or was the pneumococcus a major, if not the major cause of death in 1918? And then we just had an influenza pandemic, very mild, in 2009. I showed some data from that. And then we'll finish just with seasonal influenza. So this is a little bit about transmission. When you have, in English, it's a cold, it doesn't mean the temperature is cold. It means it's an upper respiratory viral infection. You get a lot more pneumococcal detection in humans than when they don't have a cold. This is a longitudinal study in humans. And this is a picture of transmission in the ferret. And I don't really have time to go through all of this in detail, but in the ferret, which is an animal model for transmission of influenza, you find you can transmit pneumococcus to ferrets more easily if the ferret has influenza. So it's not only that with influenza or respiratory infection you cough, you sneeze, so you could send pneumococcus to someone else. If that other person has also viral respiratory illness, then the pneumococcus can adhere very easily. So it's acquisition and transmission, and I won't go through it all. This is the ferret, this is some data in mice, but I'm just going to briefly show you this. These are some very new data, which I think will be very controversial. Because if influenza can lead to increased pneumococcal severity and also to increased pneumococcal transmission, we have a vaccine which is a live attenuated influenza vaccine. So we ask the question, can that vaccine increase pneumococcal transmission? Now nobody thinks about this. When you make a vaccine for influenza, you worry about influenza, you have a safety related to influenza, you don't think about pneumococcus. So these are some very controversial new data. It's unpublished with myself, John McCullers, we worked with him, and Michael Mina is the first author, he's a PhD student of mine. This is again in mice, and it's not so obvious and clear, but if you give pneumococcus alone, which is pneumococcus, this is a serotype 7F pneumococcus, 1 day post phosphate buffered saline, so just the pneumococcus, you get very little. This is it's this bar here. You get a little bit of pneumococcal carriage, and then you seem to get a little bit of a rebound at day 12, but it's not a good colonizing pneumococcus, and we've done it with many different strains. But if you give it 7 days again post-LAIV, which is the LAIV is the live attenuated influenza virus, the vaccine, then you get this massive increase in pneumococcal colonization in the nasopharynx. And in fact, so that's 7 days post. If you give it even 1 day immediately after the LAIV, then you get the immediate. Sorry, this is 1 day is here. So if you give it 1 day afterwards, then it takes 7 days to go up. If you give it 7 days afterwards, then it's this one, and immediately it goes up. So 7 days after exposure or 1 day after, it takes time. So what we are showing is that even a vaccine against influenza may increase pneumococcal transmission. Now these mice also they don't die. So the good thing is they don't die, and it teaches us something. Why don't they die? Well, this live attenuated influenza virus is temperature sensitive. It doesn't grow in the lungs. It only grows in the nasopharynx. So it seems you need the virus and the bacterium in the same site to have that interaction. But it does go to the middle ear. So these mice all got middle ear infections. So we are now looking in the literature to say, well, are there signals that within 2-3 days post live attenuated virus there is an issue? So we wait and see. Okay, now I'm going to talk about the Great Influenza. If any of you have an interest in the history of medicine, this is actually a very good book. It's a book about not only influenza, but how the influenza epidemic in 1918 changed medicine completely. So if you go back to 1918, where was the center of medical research in the world? It was here. It was in Germany and it was in France. And the US was behind. Now Didier will say the US is still behind.
For infectious disease.
Sure. So we're just talking infectious disease. So this book says, and it's very interesting, that the calamity, the disaster of millions of people dying, especially young people, because the mortality, as I show you, was in young people, changed medicine forever. Because you could, in the past, at that time even, you could do medicine as what we call an apprenticeship. You could just work with somebody who was a doctor and you could become a doctor. But in fact, it changed completely, and medicine became an academic pursuit, and the people looked to the researchers to say, find out why this happened and prevent it and stop us from dying. And of course, in 1918, there was no virus that was discovered. Okay? So the influenza virus itself was only discovered in the 1930s, so after this. So now we ask the question, and there's just the picture of the people dying, and you see, look here, I don't know if you can see from the back, but that's the mortality curve related to the influenza. So here's the, je pose une question, and this is the question. Did bacterial infection, especially the pneumococcus, play a major role in mortality during the 1918 influenza epidemic? So let's now take ourselves to 1918, and we are here in this room, and the influenza is coming, and how afraid should we be? You are the group who is most likely to die, but would everybody die? Well, no, in fact, not. When you look at the total case fatality rate by age, and you see this is the group here where there was a big mortality, this is a log scale, so that's 1% mortality, 2%. So in fact, only 2 people, if we have 100 people in the room, only 2 would be expected to die. Of course, when you take the total population, the population of the Earth today is 7 billion. 2% of 7 billion, I don't know, it's 140 million, I think. It's a lot of people. So you would have a lot of deaths, but it's only 2%. So who died? Well, the next thing is, I've already told you that influenza occurs in the community. So most people who got the influenza would get very sick. If you have influenza, it's not like having a cold or respiratory illness that is mild. You feel like you're going to die, and you understand why, if you are very old or weak and you're unable to breathe well, you can die, but you don't. You feel like it, but after 4 days you're better. And even in 1918, this is complicated by pneumonia, and it's about 6%. So that's 1, 2, 3, 4, 5, about 6% of individuals got pneumonia. So 94% of the people who got influenza were sick for 4 days and they recovered. They might have thought they would die, but they didn't die. But 6% then got ill again. So the influenza comes, you feel terrible, you think you're going to die, you don't die, but 6% carried on, and now they have pneumonia. And in that pneumonia group, the pneumonia case fatality rate, this is a log scale, 10%, 20%, 30%. So about a third of those who got pneumonia died. So if 6% get pneumonia and 1/3 of them die, it's 2% deaths. Okay, so that's the real story of what happened in 1918. There were a lot of deaths, 2% of the population, in some places more, in some places less, but overall it was the massive mortality in those who had pneumonia. So now the question that I ask is, were those pneumonias bacterial? And remember, in 1918, no antibiotics. Okay? Antibiotics were discovered in the 1940s, 1950s. You know the story of Fleming and all the miracle of antibiotics. So no antibiotics to treat these people. Now you wouldn't use an antibiotic to treat influenza, but you would for a bacterial pneumonia. So let's see, is it possible that these were in fact bacterial complications of the influenza? So the first thing we look at is the time to death. So I think I might have skipped one slide here. Let me go back. Sorry. This is very sensitive. Oh, okay. Yeah. So if you look at the number of deaths, days after the start of the infection and the time of the death, there were some deaths on day one. This is day one, but that's 2% of the deaths. So less than 1% of deaths were on the first day. And that's in contrast to what you often learn about 1918. People say that influenza was so severe that 4 women were playing bridge. This is a story, and you can read about it, it's published. And the next day, 3 were dead. Now, it's impossible to play bridge if you are so severely ill from influenza that you're going to die within 1 day. So it's not likely that the majority of deaths would be so early. And in fact, this is military recruits, and the peak death is around day 7. This is a lot of different studies. Remember, the war was happening in the First World War, and in fact there are data here from both German and Americans and Australians, and the median time to death was between 7 and 10 days. So the first thing we did was we took the time to death of proven bacterial pneumonia without antibiotics, and we laid the data on the green data I showed you before, and you see that the time to death is identical. Now, this does not prove causality, but it says it's possible that if these individuals were exposed to pneumococcus at the same time as the influenza, the time to death would have been similar. So, how do you do this? So you have a problem. We have a pandemic that is now 90 years old, it's 1918. How do you find the cause of death? Well, it would be marvelous if you had some histopathology specimens from the lungs of people who died. And turns out there are some specimens. So this study was a report on 58 autopsies which were reviewed in 2008 from patients who died. Now the problem here is we don't know how these autopsies were selected or why they were kept. So were they kept because of evidence of bacterial pneumonia? We don't know. But in all 58 autopsies, when they looked for evidence of bacteria, they found it in everyone. So it was certainly suggestive that bacteria were playing a major role. So the first author of this paper, David Morit, was sitting, as you are, in a lecture which I was giving about this subject, and he had already these data that were not yet published, and I could see him getting more and more excited. And so afterwards he came to me, and it turns out his passion in life, some people have a passion for rickettsia, other people have a passion for different things. His passion in his life is the 1918 pandemic. If he can find a new paper in any language, he immediately finds the paper and has it translated. And he's a little bit old-fashioned, so instead of having all this information on Facebook or on the web, it's photocopied in his office. So he told me, I asked him the question, I said, I got interested in this because we showed that a pneumococcal vaccine prevented hospitalization for influenza in children. There were pneumococcal vaccines that were tried during the 1918 pandemic, and I have no idea if they worked or not. He says, there's lots of papers on this, but you have to come to my office to find them. So I did that. So I had a PhD student, Yuwen Chen, and we went to David Morin's office for a week, and we looked through all the papers we could find on the 1918 pandemic, and we looked for evidence of two things, and I'll show you both. The one is, were blood cultures taken, or were cultures taken from the lungs of the living patients before they died? Because there's quite a lot of literature post-mortem. But we wanted to know, in the patients who got just influenza, were the pneumococci discovered, and in the patients who got pneumonia. So that's what's shown here. So let's start here. This is before death blood cultures, and this is patients without pneumonia. So this is just the influenza, the 94% of individuals who should have just got better. And you'll see that there are 5 papers from the military, 5 from civilian, and altogether about 400 cultures taken from patients where they said these patients did not have pneumonia, they just had influenza. And you see the answer is 0 pneumococci. There is 1 positive for a hemolytic streptococcus. That's not a good thing to have in your blood. At this time, they didn't know how to differentiate hemolytic streptococci, but almost certainly this would be a beta hemolytic streptococcus, Streptococcus pyogenes. And in fact, in this one paper, this one individual subsequently developed pneumonia and died. Okay? So, no pneumococcus, no bacteria if you just have influenza in the community, even in 1918. But patients with pneumonia, a lot of studies, 24 studies, more than 2,000 blood cultures, and 16% overall have bacteremia. Now, you say to me 16% is not 100%. But if we have, again, a room full of young adults with pneumococcal pneumonia, and we do a blood culture on everybody, how many would you expect to have a bacteremia, in other words, an organism in the blood as well as in the lungs? About 10%, okay? So 16% bacteremia is consistent with virtually 100% bacteremic or bacterial pneumonia. And for more proof of that, if you take your antemortem culture, not from the blood, but from pleural effusion or a lung culture, it was 80% had positive bacterial cultures. Number 1 in all of these is the pneumococcus. Number 2, hemolytic streptococci. And interestingly enough, Staph aureus, which is often discussed and can be a complication of influenza, a severe complication, but it's rare. It's severe when it occurs, but rare. It's maybe more common today because the antibiotics which you may get if you have a viral illness may not cover Staph aureus. So I think Staph aureus is coming up as a cause, but in 1918 was not the major cause associated with bacteremia. Now, this is just a nice slide showing that there were vaccines available, but the vaccines did not include the influenza virus because it wasn't discovered. So they tried, they knew this. These studies that I just showed you were done at the time. So the scientists knew that the patients who were dying had pneumococcus, had hemolytic streptococcus, and they thought those were the cause of the influenza. In fact, Haemophilus influenzae was named that because they thought it was a cause of influenza. So the studies were awful, the studies of the bacterial vaccine. So the way the studies were done is you make a vaccine, and it unfortunately takes a little bit of time, maybe 2, 3, 4 months to make your vaccine, and then you give it to people, and then you write your paper for the Lancet or whatever, and you say, look, 3 months ago, if we have 1,000 people, then 800 would get influenza. Now we have given the vaccine, and 1,000 people, and only 200 have influenza. Vaccine prevents influenza, it's proven. But we know it's not plausible, okay? Because the influenza is a virus, and these bacterial vaccines should not prevent them. So the designs, these were not randomized trials with concurrent controls. They were comparing the time when they gave the vaccine, which in almost every case was after the epidemic had peaked. So what we did in this analysis is we said, okay, let's accept there will be fewer influenza cases in the vaccinees than in the controls, but we make a new denominator, and the new denominator is influenza cases. And then we say, amongst the influenza cases, were there more pneumonias among the vaccinees or less than the controls? And what we showed, again, it's not perfect because it's long after the time, but all the papers where we had the information about the vaccines, we found about, this is the odds ratio, so about a 40% reduction in pneumonia hospitalization in those who received the bacterial vaccines, and also a reduction about 50% in deaths. Okay, so now we go on. We had been working on these things. We had some information that pneumococcus is contributing to pandemic influenza mortality. And we're sitting in 2007, and everybody is spending millions, billions of dollars to prevent mortality from the next pandemic, and nobody is talking about pneumococcus. It's all influenza, influenza, influenza. Now, if you have an influenza vaccine, it's wonderful because it prevents everything. It prevents the influenza in the community, it prevents the severe influenza associated with the pneumococcus. But you have to have the vaccine in time. And of course, in 2009, we still couldn't make a vaccine in time. Okay. So the question was, if you want to prevent mortality, surely you should also be considering pneumococcal vaccine to prevent mortality. So now we're going to come to the pandemic of 2009, much milder pandemic. But first I want to tell you just a little bit about pneumococcal vaccination, because it turns out you can prevent pneumococcal disease, again, only for the types which are in the vaccine, in the whole community, just by vaccinating the children. And the data that support that, and there are data from Europe also that support it, so this is a picture of the types. Now we're dealing with the pneumococcal 7 vaccine. This is the commercial vaccine which was introduced. It's in France. Everybody, every child lucky enough to be born here will get now this vaccine. But this is the time of the before the introduction in the US. So 98, 99 were the last 2 years before the vaccine was introduced. It was introduced in January 2000, and the cases, the PCV7 type cases coming down. And now it's down, we're out here in 2012, it already was 100% reduction. So that's fine. The vaccine prevents disease in young children less than 2. But what about the elderly, over 65? They didn't receive the vaccine. The vaccine's only for children, new babies. The vaccine is given at 2, 4, 6 months and 1 more dose in the second year of life, none to 65-year-olds. Here is those same serotypes included in the children's vaccine in adults over the age of 65, nobody vaccinated, and by 2007 it was a 92% reduction, so it's a slower reduction, but these strains are not circulating anymore in the United States. This 92% now in 2012 is 99%, okay? So the vaccination of young kids can interrupt transmission of strains in the community, and this makes this a very attractive vaccine for pandemic influenza hospitalization prevention due to the pneumococcus, because you just vaccinate the children and the strains don't circulate. And I'm not going to go in great detail through that. Let's now come to 2009. So the first question is, what, if anything, was the role of pneumococcus in mortality in 2009? Well, there was not a lot of mortality because this was a virus that was less severe and maybe less likely to lead to pneumonia. There are very few deaths in children in the United States from influenza each year, 77, 88. Here's the pandemic it was in 2 waves in 2009. So there was an excess mortality in young children, 269 deaths. When you look at the autopsy in the 269 deaths, only 144 even had a specimen collected for bacterial culture, and amongst those where a specimen was collected, a third of them had bacteria. So in contrast to 1918, where we believe that it was probably 80% who had a bacterial co-infection, I think it's more like a third of the deaths may have been associated. But our culture techniques are not perfect, so it may be more than that. But that autopsy study suggested a third. This is a picture of a subset of those. This is adults as well, those 77 patients, and some pictures of pneumococcus and other bacteria in the histopath specimens. This is from New York, 34 autopsies, evidence of bacterial co-infection in 55%, so a little bit more. I'm not going to go through all of these. This is perhaps interesting just because it's now in humans. It's a small study, 21 patients who died of confirmed H1N1, and bacterial co-infection found in 38%. But they say in the paper there was marked Interferon-Gamma expression in the lungs. So interesting, going all the way back to the mice and Interferon-Gamma as a mediator. I'm going to move through that quickly. Okay, I want to show 2 things about severity in 2009. This is a study which was quite interesting. It's done in Argentina. And they found 39 severe cases. So how were the 39 severe cases defined? Well, I think you will agree that they were severe because 19 were hospitalized and 20 more died. So the 39 were 20 deaths and 19 hospitalizations. And they compared them to 160 mild cases in the community. Some people in this room might have had that influenza. And essentially, when you read through all of this, what they found is in young people who were not expected to die, so if they were between 5 years of age and 55 years of age, or 6 to 55 years of age, if they had a pneumococcus in the nasopharynx, the odds for severity, that means hospitalization or death, was 7.4-fold increased. And if they then further were able to deal with confounders, which were comorbidity or another infection such as RSV also detected, then the attributable risk of severity was 125-fold increased. So that's kind of interesting. And here's the only study I could find from France, but it's a good one. So we'll go through quickly. So, well, except that it's from Paris, I'm sorry. It's not from Marseille. So it's an interesting study because it's an intensive care unit study of severely ill patients with proven H1N1 and rather nice, no previous antibiotics. So it's trying to exclude patients who are already treated with antibiotics. And they identified bacteria again in 46%. So again, about 50% had antibiotics, mostly pneumococcus. There's the proportion. It's amazing because the same bugs are there from 1918 to 2009. Pneumococcus, Staph aureus, Group A streptococcus. They did procalcitonin. This is a biomarker of bacterial infection. And remember, all of these are proven H1N1, so proven viral infection. And here's a procalcitonin level of 0.8 micrograms per mil or more, and that was associated with more severe outcome, which was the need for ventilation or death with an odds ratio of 7. So again, the severe cases, the ones who are in intensive care, there's evidence they have bacterial infection as well. I'll skip this because it's the same one. You can ask the question, was there an increase in bacteremia due to pneumococcus in 2009? There are a lot of papers that suggest it. This is the age 5 to 19. This is the excess bacteremia. I don't want to go through all of these. New paper just come out now with excess pneumococcal bacteremias, mostly in the 5 to 24-year-old age group. Let me go. Oh, this is, again, it's too complicated, I think, for me to go through in detail, but we modeled the 1918 pandemic and said there were many things different in 1918. As I said, no antibiotics. The young people who died, if I were to take a nasopharyngeal swab from everybody in the room today, I would expect about 10% to be positive. Okay? In 1918, if we did the same exercise, same people, same age, we would expect about 40 to 60% positive. Okay? And I think that antibiotics have completely changed the ecology of the pneumococcus. So this modeling exercise suggested just the change in pneumococcal frequency of colonization could explain much of the severity and mortality of the 1918 epidemic. But just this one from your next door neighbors here from Spain, Spanish case control study, and this is again hospitalization for pandemic influenza in 2009. Receipt of pneumococcal conjugate vaccine was associated with 48% reduction in H1N1 2009 pandemic influenza admission. So we come full circle. Remember, I started with 45% reduction in children. I didn't tell you that study was in Africa, in South Africa. And now we have, again, it's not quite as elegant, it's not a randomized trial, it's just an observational study, but the same type of story. So back to seasonal influenza. I don't think I have time to go through all of this, but we believe that this happens every year. So most individuals get influenza, get sick, but they recover, they don't get the pneumonia. The question is how many get pneumonia, and it's a small number. About, in the 2009 pandemic, 1 in 1,000 who got influenza in the community got the pneumonia. So yes, I don't want to give wrong messages here. You could give antibiotics to all 1,000 people. 999 would be for no reason and just creating resistance in the antibiotics, but you would save the one. And so it's not useful to give antibiotics prophylactically. But if a patient comes into the hospital with pneumonia, even if you find influenza, you have to give them antibiotics because the combination you can't always discover. So my conclusions, there is significant evidence that the majority of deaths during the 1918 pandemic were associated with a synergistic lethality of bacterial infection, mainly the pneumococcus. For 2009 H1N1 pandemic, data suggests significant role for bacterial pathogens in at least a third of deaths, in the severity of the disease, and the pandemic increased presumed bacterial pneumonia admissions. I didn't show that, but it was on the slide. And IPD is invasive pneumococcal disease. Influenza and even live attenuated influenza vaccine may increase pneumococcal transmission, and pneumococcal vaccines may reduce mortality, morbidity associated with viral respiratory infections. Now, I haven't spoken about the other viruses, but it's probably the same. So adenoviruses can do this, RSV can do this, parainfluenza can do this, human metapneumovirus can do this. So most of the viruses can lead to a short but important susceptibility to bacterial comorbidity. And when the two come together, it's a problem for the human. And then finally, I say antibiotics may be an essential part of the management of influenza-associated pneumonia, but prophylaxis, even those with proven influenza immunity, is not advised. So we'll see.
Thank you very much. I think that it's probably true that not only for pneumococcus but also for staph, that and strep those, that people living without common use of antibiotics are much more colonized. So we are doing work in rural sample, and I'm really impressed. We are looking for skin swabbing for diagnosis of skin infection, and then we take controls on normal skin. And the number of positive carriers on the skin of staph, strep and pneumococcus on the skin is common, very common. So that means that what we analyze in the antibiotic time is a completely different ecosystem that was there before.
So that's true. So so when I said that if we did a nasopharyngeal swab of this group, we would expect 10%. If you go to Senegal or the Gambia, you would expect 40%. So that's why we think it's antibiotics. So yes, and unfortunately, the data even in 2009 of influenza severity in developing countries is very little. So there's so many other causes of death, but almost certainly in 1918, the mortality in the poorest parts was greater than in the developed. And it has to do with crowding and levels of transmission and so on. But yeah, it's it's another thing that I'm interested in is the bacterial interaction. So in the nasopharynx, we have a recent study from Peru which suggests that Haemophilus influenzae in the nasopharynx interacts with Pneumococcus, and the two are synergistic, they go together. So it's not impossible that influenza will drive up the density in the nasopharynx of virtually any bacterium that is there. And once the density increases, the possibility of aspiration and pneumonia will increase too. So yeah, we do have, it leads to a possibility of a new diagnostic, which we have a paper that we published last year in adults, which showed that you get a massive increase, and we have been talking about in the nasopharyngeal density as a risk for pneumonia. So that may be the mechanism or part of it.
I am in charge of hospital infection control here, and we are promoting every year a campaign of vaccination before the epidemic. But what you're suggesting here is that I should not recommend vaccination once the epidemic has started.
Well, yes, I do have some concerns about, I mean, it's always a question, a balance of risk and reward. So I'm a strong supporter of influenza vaccine. I have it myself every year. And clearly the best time to give it is before the influenza is there. Once it is there, the question of the usefulness of a vaccine within an epidemic, it really goes to quite a lot of other issues. But it does suggest there could be problems. The immune response to the vaccine can, for a very limited period, before you get your antibody, I believe, distract the host immunity from the virus itself. But, you know, on balance, even if you give it during the epidemic or during the time of flu, one would suspect that you'd have to look I'm not sure that I would go so far as to say stop vaccination once the influenza arrives, but you could make an argument along those lines. Well, you know, I think whatever the vaccine does, influenza would do as well. So in fact, yeah, as I think it through, I would rather have the vaccine than have the influenza. Of course, you know, we have problems with influenza vaccine. The latest estimates of this year's vaccine effectiveness in the US is 47%. So it's no better for severe disease than the pneumococcus vaccine. But so we need a new and improved influenza vaccine. We need a vaccine that doesn't have to be given every year. Most of my work, I was explaining to Didier, I'm now working with the Gates Foundation to prevent pneumonia in developing countries. And so one of our areas of interest will be to help support research for a cross-protective influenza vaccine, because the industry is not so very interested. They make good money giving a poor vaccine every year to everybody. So a good vaccine that would protect for 10 years may be not as attractive. So we have a big challenge with influenza vaccine.
So would you recommend, which was what I did recommend at the very beginning of 2009, I recommend the doctor to vaccinate against pneumococcus and treat with antibiotics people who have having fever for more than 3 days, which was what, and I still believe the same. So would you recommend in people, and this is something we need to think about for our personnel, very well exposed to influenza, not only to propose influenza vaccination, but also pneumococcal vaccination?
So we don't have enough data at the moment to know whether it's useful or not useful to vaccinate at the point that they already have the influenza, because the vaccine is going to take 2 weeks to...
No, but I mean on a regular thing.
Oh, yeah.
For personnel exposed to pneumonia, should we vaccinate our personnel?
So our problem we've had up to now, and we haven't really discussed, is that the adult pneumococcal vaccine has been poor. It protects against bacteremia, but has not really been shown to protect against non-bacteremic pneumonia in the high-risk groups, so in the elderly, in those with comorbidity. It seems the conjugate vaccine may be better. There's a large trial going on in Holland at the moment in 80,000 adults, and the results are expected next year. And it may work better, but the best way to protect everybody is to immunize the kids. Because once you immunize the kids and you interrupt transmission, then everybody's protected from the pneumococcus. So I don't see, I mean, we had a lot of debates about whether you need to give pneumococcal vaccine to adults at risk for influenza hospitalization. I think unless there were a very severe pandemic, or unless there were people at particular risk, at the moment the strategy is obviously to try and make influenza vaccine, make it available as quickly as possible, and then simply to vaccinate all the kids in the community to increase herd protection. That's the goal.
There is a big issue, big discussion now with RSV in developing countries.
Yes.
And when you showed the only number I could get is 60% reduction of hospitalization, so I need to receive the vaccine.
Yes.
So can you comment on that? Do we know something about the mechanism? Is it the same mechanism as interferon?
Yeah, there's been one study only, Voivant, you know him from Quebec. He's done a study on RSV and pneumo in mice. But we don't have as good data overall on RSV. In our original study, we did find some protection against RSV. You know, the problem with RSV is we don't have an approach to RSV vaccine, except one, which is what we will also now support through the foundation, and that is maternal immunization. So for RSV in the first 6 months of life, which is where there's a lot of mortality, we know that you can protect children, infants, with monoclonal antibody. Palivizumab is the monoclonal antibody, protects against RSV. So if you take the same protein, which is the RSVF protein, give it to pregnant women, let them make good antibodies, and that should protect their infants. So it's a little bit controversial because you're giving a vaccine to mothers to protect their infants rather than to protect themselves. But of course, viral infections, even in pregnant women, are a big issue. We know more about influenza in pregnancy than RSV. But for me, that's low-hanging fruit, and I think we're going to support studies like that. Yeah.
Are there differences regarding the type of influenza virus?
Yeah. So good question. It's interesting. At the European meeting at ESCMID, I have to have a debate against a famous influenza person, and the debate title is about the types of influenza are important or not. So he has an easy job to say yes, they're important. I have to say they're not important, and I will give a talk along these lines to say, well, it's actually the bacteria. But even within that, there is some evidence like H3N2 is more associated with pneumonia, particularly in the elderly, than H1N1. And so people have looked at the neuraminidase to see whether it impacts on, because neuraminidase is also produced by pneumococcus. And so there's some data which suggest that the neuraminidase, which cleaves mucus, can expose receptors which the pneumococcus can adhere to. So there may be some differences. There's one paper about presumed bacterial infections associated with influenza related to the influenza type. And it suggested H3N2 as a little more than H1N1. So it wouldn't surprise me if there are not differences in the ability of influenza viruses to lead to bacterial secondary infection. H5N1 is a case in point, the influenza virus in birds. I mean, there seems to be, there are many issues. Its pathogenicity is largely related to the specificity of the receptors. But it would not surprise me if it's not able also to lead to bacterial infection. It's just that in the susceptibles, they're in big trouble anyway when they get it.
Well, thank you.